Thank you for coming and not coming. Thank you for being home, or thank you for being in your office or wherever you are. So my name is Yoshi Terauchi. Do you hear me? It's strange because I don't see any audience, so it's like I'm talking to myself. But if you don't hear me, just let me know by raising your hands or something. Maybe not. So I hope you hear me. If not, I just wait. So anybody tell me I'm on live? Anybody? Lina, can you hear me? If so, please text me. Otherwise, I will start talking. Okay. Okay, it's almost 9 o'clock in Japan and 12 o'clock in Europe, I think. So good morning and good afternoon, good evening, and good night, but don't go to bed yet. So the title of my presentation today is How about MTA obturation? Because I stopped using gutta percha and sealer because it doesn't work so much. So that's why I've been using MTA for more than, let's say, 22 years right now. And I completely stopped using gutta percha and the sealer since 2012, if I'm correct. So let's start. So by the way, my webinar is supported by a microscope company, Zoomax. So that's why I like to show some respect for them. So this is a comparison because I've been using my microscope, Zeiss OpMe Pro Ergo, since 2013. But the first time I bought my Zeiss was 1995. So since 1995, I have used my Zeiss microscope and I enjoyed it. But you know, when I met the Zoomax, I changed my mind, and it was completely different. I mean, actually, the initial Zoomax microscope was as good as my Zeiss microscope. So let me show you. Because I bought my Zoomax OMS 3200 just 2 weeks ago, and I like to show you the comparison between the Zoomax and Zeiss. So on the left, you can see the image of the Zoomax. And if you compare the two microscopes, Zoomax and the Zeiss, and the clicking sound, if you want to unlock the magnetic clutches, it makes very quiet sound. If you compare the sound of the Zeiss, it is a little bit louder. So let me show you the differences. Another difference between the Zoomax and the Zeiss is inclination angle. So it's, you know, you can tilt the microscope to 60 degrees with your Zoomax, but if you like to tilt the Zeiss Pro Ergo, you can turn it to like a 30 degrees. So let me show you the difference. Okay. Excuse me. I like to connect. I want to connect. Excuse me. What is this? I don't think you can see my video. So let me just a moment. Okay, here. Okay, one more time. So this is a Zoomax. So you can turn it like this, 60 degrees. Okay, you can go like this, 60 degrees. So you can have sometimes direct vision because you can turn it like this. And there's almost no clicking sound from the Zoomax microscope, OMS 3200. But if you use the so here, if you see the dice, it's a little bit different. By the way, do you hear the sound? The audio is working. So if you tilt the ice microscope like this, it makes a 30-degree inclination. And the clicking sound is louder than the Zoomax. Okay, did you see the video? Okay, if not, let me show it again. Okay, something wrong with this. Oh, I shut down. Okay, I'm sorry about the confusion. So let me show you the video again. With the video. I'm sorry about the time I'm consuming. Do you see the video, by the way? Do you see the video? It's on my computer, but I don't think it's on the Zoom. No, I don't think so. Okay. This is something different. Okay, I'm sorry about the time I'm taking up. Okay. Okay, now. Video. Anyway, I'm sorry about this. Sorry, I'm sorry, I cannot show you the video. I don't know why it's not connected to the Zoom, but anyway, you know, the Zeiss microscopes, you know, make a bigger noise than the Zoomax. And this is the difference between the image of Zoomax and the image from the Zeiss Pro Ergo. I don't see any big difference, but I think if you look at the image from the ZoomX, it's a little bit brighter. And this is a difference. On the left, you can see the image from the ZoomX OMS 3200. On the right, you see the image from the Zeiss Pro Ergo from the same camera, because I use the same camera. So this is the difference between the ZoomX image from and the Zeiss image. So okay, let me continue because this is not very important. But anyway, my impression on the ZoomX OMS 3200 is a little bit better than Zeiss Pro Ergo. That's what I felt about it. So you can actually magnify the image about 2 times with the ZoomX. So by the way, this is a topic outline. I'd like to start my presentation with characteristics of garapacha and the serial. Then I'd like to talk about the characteristics of MTA and instrumentation for MTA obturation and MTA obturation technique. Then I'd like to show you some clinical cases at the end. So let me start with the characteristic of garapacha. In other words, why I don't use garapacha. So I'd like to show you the reasons why I do not want to use garapacha and the serials as a root fitting. So first of all, this article shows on the surface of the apically extruded garapacha points, you can see biofilms found containing bacteria and toxin. So in other words, if you extrude garapacha beyond the apical foramen, you will have more bacteria on garapacha. So garapacha can be easily contaminated with bacteria. Biofilms may grow on garapacha cone and garapacha can get dirty. So that's why this is one reason why I do not want to use the garapacha. So this is a case from my practice. I found this on the first appointment with my patient. I took a radiograph. I found a big lesion on the root. You see the big lesion here. And the garapacha was extruded beyond the apical foramen, as you can see here. And what I did was I retreated this tooth, but I separated the garapacha cone. So you can see the garapacha separated from the main cone in the canal. But I had no choice. So I filled the canal with MTA, and this is a 6 months post-op showing the lesion completely reduced. But the lesion stayed for another 6 months in the same size. So I decided to do the surgery because I wanted to finish the case. So what I did was I just removed the garapacha cone here, extruded from the root canal. I took it out with my surgery, and this is 3 months after the surgery. And this is 1 year after the surgery. As you can see, nice periapical healing after the removal of the garapacha cone left in the bone. So I think the garapacha was the only reason creating a periapical pulsosis. So as soon as I removed the garapacha in the bone, I started seeing the lesion getting bigger, getting smaller and smaller. And if you extrude garapacha into the sinus, maxillary sinus, you may have a problem. You may develop aspergillosis, like this. So garapacha can be, easily contaminated, even in the sinus. So that's why So there are actually many reasons why I do not want to use garapacha as a root filling. And according to this study, more apical healing with cases that had garapacha and sera root fillings within 2 millimeters of the apex than those with overextended root fillings or those with fillings more than 2 millimeters short of the apex. So if you want to use garapacha and the sera to fill the canal, you have to be 2 millimeters short of the apex or within 2 millimeters short of the apex, but do not extrude garapacha. You may fail. Or you shouldn't be, underfilled more than 2 millimeters. Why? Because, if you extrude the garapacha, you may have some defect unfilled. And according to these studies, small spaces with necrotic tissues may also be vulnerable to biofilm formation when garapacha root fillings was used, unlike MTA. However, MTA obturation has an advantage in these challenging cases because of setting expansion and antibacterial activities. So this is another reason why I want to use MTA rather than garapacha and the sera. So why, if you extrude garapacha beyond the apical foramen, the case may fail. There are some reasons why extended garapacha does not seize the canal. Because if you apply pressure when you're compacting garapacha with heat, you may touch the canal walls because of the pressure. But if you extrude garapacha cone into the bone, there's no pressure against the canal walls. Therefore, you will result in leaving some spaces on the canal walls. So you see the spaces like this. So that's why if you extrude garapacha, if you overextend the garapacha cone, there's no seal around the apex. That's why bacteria will grow here. But if you use MTA as a root filling, MTA always expand, leaving no space unfilled because of the expansion. So that's why MTA is better. So in summary, why garapacha fillings are not good for root fillings. One reason is root fillings, garapacha root fillings to the canal terminus do not always lead to successful endodontic outcomes because garapacha does not bond to dentin. Garapacha does not carry an antibacterial activity. It doesn't kill bacteria. So this is another reason why MTA is better than garapacha. And the third reason is garapacha can be easily contaminated with bacteria that may form biofilms. And contaminated garapacha remaining inside or outside the root canal can be, I went too much. Can be a major cause of apical periodontitis. This is called garapacha-centered infection. So garapacha can be the only cause of the periapical disease. So there are many reasons actually why you do not want to use garapacha as a root fillings. So this is a case from my practice. I retweeted this tooth. Actually, initially I did the treatment myself. And after several years, I didn't see the lesion going away. So I decided to, by the way, I used garapacha and the sera for this case. So what I did was I replaced garapacha with MTA. That's what I did. Okay. So this is the post-op, 1 month, 3 months, 5 months, 8 months, showing complete periapical healing, as you can see. What I did in this case was just replaced gut aperture with MTA. That's all I did for this case. Very simple. What is the difference? The difference is MTA kills bacteria, MTA expands over time, and there's no space between MTA and dentin. So let's talk about characteristics of MTA. So there are key properties of MTA that you have to keep in mind. MTA produces hydroxyapatite layer between dentin and MTA. And the particle size of MTA is very small, 0.5 to 3 microns, actually smaller than the size of dentinotubule. So you can get MTA into dentinotubules because it's smaller than that. And MTA is bioactive. MTA promotes cementogenesis, odontogenesis, osteogenesis, and also it will induce PDL reformation. So gut aperture is not bioactive, but MTA is bioactive. MTA is hydraulic. It will set in a wet environment. Inside the root canal, it's always wet. So it's very nice if you use MTA instead of gut aperture and the sealer. MTA releases calcium ions during its setting reaction and provides an alkaline environment to kill bacteria. MTA is highly biocompatible. So even if you overextend MTA, it's okay. Nothing will happen. And the good reason for higher sealability of MTA is this, because MTA produces hydroxyapatite layer between MTA and dentin interface. So that's why there's no gap, no space, 0 micron between MTA and dentin. Because of this, as you can see here. So how do you eliminate biofilms inside inside the space that you cannot touch with files? Because you can touch about 30% of the root canal walls with your instrument. 70% you cannot. So this is good. This is a solution to it. If you mix MTA with phosphate buffered saline called PBS, promotes crystallization and bacteria entombment, leading to elimination of bacteria in the canal. So I always mix MTA with PBS because it expands more. It creates more seal between MTA and dentin. So as you can see, these pictures were provided by Professor Yu here. So you can see bacteria, you can see cocci and rot here. And if you obturate the canals with MTA, you can see the crystallization inside the dentinotubules, killing bacteria. And more antimicrobial fungal activity with MTA. So if you have like a smear layer between, on dentin, you have more tight seal here. So MTA obturation MTA obturation provides more sealing ability with smear layer on dentin. You see, there's no gap between MTA and dentin. This is an image 5 years after MTA obturation. 7 years here, there's no gap. 8 years, no gap. See, I don't see any interface. So, it's better not to leave, smear layer using EDTA. It's better to have smear layer when you obturate the canal with MTA. So this is another study showing, supporting the theory of leaving smear layer on MTA to have more sealing ability. So this study shows sealing ability of MTA is significantly better with smear layer present on dentin surface than without it. So EDTA is actually not necessary for better sealing, but if you removed or if you use EDTA, you can create smear layer just by scratching the canal walls with your file. I always do this to have more sealing abilities. And MTA can seal internal resorptive defects and eliminate possible effects of pathogenic biofilms and bacteria harbored in dentinal tubules. So actually, if you obturate the canal with MTA, you can kill bacteria. And this study also showed MTA obturation removes biofilms 70%, between 68 and 77%. If you use premixed MTA, like BC sealer or bioceramics putty or something like that, the initial initial 24 hours, you have higher antimicrobial activities, 70%. As the time goes by, you will decrease the antibacterial activities. But if you mix MTA with water or PBS, the initial 24 hours, you don't see a big antimicrobial activities, 18% for gray MTA, 51% for white MTA. But after two days, you see the antimicrobial activity is going up. So you need to wait if you want to mix MTA with water or PBS. But if you like to use premixed MTA, the initial 1 or 2 days is the key to be successful in eliminating the biofilms. So anyway, if you use MTA as the root fillings, you can also eliminate the biofilms. And this study shows calcium silicate-based sealers like MTA Filafex or BC sealer exhibited anti-inflammatory effects. So whenever the patient is in pain, doctor, my tooth is hurting, I'm in a big pain, please do something about it. Then this is a solution to it. You can use MTA as a root fillings. You can extrude MTA so the patient, will be less painful. Because this study shows MTA has an anti-inflammatory effect and it will induce osteogenic differentiation. So actually, this is another reason why MTA is better, especially for the patients in a big pain. And this study showed if you are underfilled in the vital cases, if you didn't reach the apical foramen, but if you filled the tooth with MTA, don't worry about the space. hard tissue grow into the space with cementum. You see this is MTA, and this used to be space, but as you can see, a hard tissue formation in the defect, including lateral accessory canals here and here. So it's very nice. Even if you underfilled in a vital case, the body will take care of it if you obturate the canal with MTA. So this is a good example of that kind of case. So this is pre-op. This is an image from the CBCT. On the sagittal view, you see the defect here. You see the big defect on the lingual aspect. You see a kind of lateral canal here. But I was underfilled. I couldn't fill the space here. But however, this is a 3 months post-op, 5 months here. But as you can see, there was no defect. You see the hard formation, hard tissue formation in the defect right here. If you compare the pre-op radiograph and the CBCT image here, you see a big defect, deep pocket. But after 5 months, you see the hard tissue formation. This is a bone actually in the defect. But as you can see, there's no lateral canal filled with MTA. But regardless of the space unfilled, you see the hard tissue deformation in the defect. And what will happen if you extrude MTA beyond the apical foramen? Don't worry about it. This is a famous study done by Professor Mahmoud Torabinejad. On the left, he extruded MTA into the periapical tissues here. On the right, he used actually amalgam. He extruded amalgam into the periapical tissues. But as you can see, this is a histology. The animal was sacrificed, and he examined the histology here. You can see hard tissue formation around the MTA pushed beyond the perforation here. So you will see hard tissue reformed on MTA, directly on MTA. So even if you extrude MTA, it's better to extrude MTA to initiate hard tissue formation. So this study showed MTA induced significantly more hard tissue formation than garapature, which did not induce hard tissue deformation. So actually, you have to contact vital tissues to initiate induction of hard tissue formation. So even if you do a vital pulp therapy, you have to push a little bit to the pulp tissues to initiate hard tissue formation. I'm talking about dentin formation. So that's why it's so important when you obturate the canal with MTA to touch the periapical tissues. That's why it's better to it's better to extrude MTA in order to initiate bone deformation in the defect. Because according to this study, in contact with vital tissues, MTA stimulates immune system cells to release lymphokines that induce cementum repair and regeneration and activate bone markers required for biomineralization and healing of periapical bone defects. So what is the chemical reaction of MTA to produce hydroxyapatite layer? Actually, when you mix MTA with water, the first chemical reaction is to produce calcium hydroxide. Then you will see calcium phosphate. Then on the calcium phosphate, you see the deposition of hydroxyapatite. And if you have hydroxyapatite, you know, the vital tissue around it love being on the hydroxyapatite layers. So if you look at the osteoblasts on hydroxyapatite, they love being on it. So this is a good study. So if you incubate osteoblasts on amalgam, they all died. If you incubate osteoblasts on IRM, they all died. But if you incubate osteoblasts on MTA, you see them, you know, proliferating, you know, without disturbance on MTA. So they enjoy being on MTA. In other words, they enjoy being on hydroxyapatite. So this is another study showing the same thing, actually supporting the same thing. MTA, but they concluded MTA is better for MTA obturation. But, sorry, what I'm doing here. But if you want to do the vital pulp therapy, biodentin or BCRRM root repair materials are better than MTA when it comes to dentin formation. They are looking at the odontoblast. When they are looking at the bone growth, they saw the osteoblast. They counted the number of the osteoblasts they got after the study. So according to this, sorry, what I'm doing here. So according to this here, you see more bone or dentin regeneration when MTA was in contact with vital tissues or extruded into the periapical tissues. So again, underfilling of MTA is not ideal. You need to touch the periapical tissues if you want to be successful in inducing bone regeneration. So actually, MTA obturation is more preferable for the foreign cases here. So if you have internal or external resorption, MTA is very good. If you have C-shaped canal, MTA is good. If you have perforation, MTA is the material to use to repair the perforation. If you have an open apex, MTA is the material to use to close an open apex. And if you have endoperio complication, MTA is better to induce PDL reformation. And if you have a tooth that may need surgery in future, maybe it's better to close the space with MTA. So in surgery, you can just resect the root end. That's it. There's no need to, retrofill. And if you have a case where surgery was not successful, MTA is the material you use. If you have a challenging or complex case, MTA is a material to use as a root filling material. So in conclusion, MTA should always be used as a root filling material because MTA sustains high pH, alkaline pH, and stays bactericidal, and that lasts many, many months, more than 10 months. MTA forms interfacial layer with dentin similar to hydroxyapatite. So that's why you have very, very good sealing ability between MTA and dentin. MTA seals the canal at 0 microns under the SEM. So even if you see the gap, try to see the gap between MTA and dentin, no gap existing between SEM. And MTA can occlude dentinotuberous because MTA particles, the particle size of MTA is smaller than the size of dentinotuberous. MTA promotes cementogenesis, osteogenesis, and the PDL reformation. I keep telling this because this is a good characteristic of MTA. MTA increases resistance to root fracture, while the Garapatcha doesn't carry any resistance to root fracture. And MTA has, as I told you, antibacterial effects to, if you have a dentin next to it. So it's better to contact dentin, it's better to contact vital tissues when MTA is used for the optimal results. So now let's talk about MTA obturation technique. If you talk about MTA obturation technique, MTA obturation starts with root canal preparation. So before you touch the tooth, you need to make a treatment plan. If you want to obturate the canal with MTA, you don't need bigger taper. But if you are planning to obturate the canal with Garapatcha and the sealer, you need tapered resistance. So you need an instrument with a bigger taper. But if you are planning to use MTA as a root filling material, you just need several instruments because you don't need to create a taper, bigger taper. So this is a comparison in preparation. If you want to use MTA or Garapatcha, as I told you, you don't need a bigger taper for MTA obturation. Whereas you need a bigger tapered preparation for Garapatcha root fillings. So you can be minimally invasive if you want to obturate the canal with MTA, because it's not necessary to create a taper for MTA obturation. So if you compare the properties of MTA with Garapatcha, as I told you, MTA expands during setting. But if you look at the Garapatcha shrinks. It's not good. If something shrinks, you see the gap between the root filling and the canal wall, like this. You see gap here, another gap between Garapatcha and the sealer. Garapatcha and the dentinal wall. And you will have interfacial layer consisting of hydroxyapatite. MTA, as I told you, is bactericidal, but Garbacha is not. And I already told you these things. So this is the techniques to obturate the canal with MTA. First, you have to prepare the canal. You need to negotiate the canal with a small K files, number 10 or 08. Then you create a glide path. Then you will use a nickel titanium rotary instrument to shape and clean the canal. I recommend martensitic phase nickel titanium rotary instrument because it's very flexible and it is resistant to separation. And after the preparation, so measure remember the final preparation file. You have to choose the instrument one size or sometimes two sizes smaller than the epical preparation size. For example, if you finished your preparation with a number 4004 instrument, you need to pick up number 3504 instrument to compact MTA. But if you have a severe curvature, like more than 30 degrees or 25 degrees, you need to choose an instrument, two sizes. I recommend two sizes, smaller than the final epical preparation size, because you don't want to feel any resistance during compaction. And you can just use an up and down motion on the instrument to push MTA to the apex. So if you keep pushing, pulling on MTA, you will condense MTA further into the apical 1/3. Then you can use a bigger instrument to compact MTA for the middle 1/3 or for the coronal 1/3. You always have to be connected to an apex locator, so you know where you are during MTA compaction. So be careful when you instrument the canal and the curvature is greater than 25 degrees. So before you touch the tooth, you need to make a treatment plan. Measure the curvature. If you have CBCT, you can measure the curvature 3-dimensionally. But if you don't have a CBCT, you have to take a guess. But guesswork is not very good. So if you don't have a CBCT, you need to have CBCT to be more successful in instrumenting the canal. So anyway, be careful when the curvature is greater than 25 degrees. 75%, the curvature is less than 25 degrees. You don't have a problem in instrumenting the canal. Everything is easy as long as the curvature is less than 25 degrees. If the curvature is between 27 degrees and 35 degrees, you are still okay, but sometimes you may have a problem instrumenting the canal to the working length. When the curvature is greater than 35 degrees, more than 35 degrees, that's about 10%. That's considered severe. So you may have a problem. You may have difficulty in instrumenting the canal to the working length. According to Wu, in 2011, 54% of the instrument separated when the curvature is greater than 25 degrees. So you need to measure the curvature to avoid the breakage of the instrument. So if you broke an instrument inside the root canal, you cannot obturate the canal. You need to take it out to be successful in the treatment. So that's why you don't want that to happen during instrumentation or MTA obturation. So I really recommend flexible martensitic phased nickel titanium instrument for MTA obturation, including instrumentation, because they are more resistant to fracture and transportation. Very, very flexible. One of them that I use is high flex EDM. This is my recommendation. Very, very good. If you have a straight canal, it doesn't matter what you use. But if you want to instrument the canal with a curvature greater than 25 degrees, consider using these instruments to be successful or to avoid any accidents during instrumentation and MTA obturation. You know, because if you use martensitic nickel titanium instrument, everything becomes easier and less time. And because you don't have to use crown down technique, you don't have to use step back technique. Because of the flexibility, you can just shape the canal at the same time. So that's why you basically, you just need 2 or 3 instruments to complete instrumentation. So now let me show you how to mix MTA with phosphate buffered saline. So just you have to use, so just prepare some MTA and put it on the grass strap like this here, and use PBS, phosphate buffered saline, and mix it with it. So let me show you how you do this. So this is PBS. This is also MTA. I'm mixing MTA with PBS. This is also MTA. So you can have a creamy consistency like this. It feels like a yogurt. Then I'm going to use a plugger, small plugger, to carry mixed MTA into the canal. Okay. And so if you mix MTA with PBS, you are going to carry the mixed MTA into the canal. You put it in the canal and push it a little bit into an apical direction. Then you must pick up the instrument one size, if it's a straight canal, one size smaller than the apical size. If it's a severe curvature, pick up the instrument 2 sizes smaller than the apical size. And you have to be connected to an apex locator. So make sure you extrude MTA beyond the apical foramen to initiate the promotion of osteogenesis or odontogenesis or whatever you want. Okay, you have to be in contact with the vital tissues. Then you have to use mainly a push and pull motion on MTA. And you need to rotate the file, the instrument, one side smaller than the apical size, counterclockwise. Rotate the file counterclockwise so you can condense MTA more into the apical portion. And you can apply ultrasonics to the instrument to, remove voids, or condense more. So if you have a lateral canal, I definitely use ultrasonics to get more MTA into small spaces like a lateral canals or apical ramifications. Then if you finish compaction for the apical 1/3 and the middle 1/3, I will use a plugger. To condense MTA for the coronal 1/3. This is what I do. So let me show you how to obturate the canal with MTA for the 90-degree curved canal. So you see the right angle. This is definitely a difficult case. So that's why I used martensitic instrument, high flex EDM. So let me show you the instrumentation. First of all, you need to use a small K file for the apical patency, up and down and up and down. So you have to use the number 10 K files 50 times. Then I'm going to use number 1503 high flex EDM. So remember, I'm using a reciprocating motion, 360 degrees clockwise and 30 degrees counterclockwise. See, 360 degrees clockwise and 30 degrees counterclockwise. So this is the safest way to instrument the canal. By the way, it's rotating at 500 RPM. So I can maintain efficacy of instrumenting the canal. So I'm switching to a bigger instrument, 2005 high flex EDM. I'm going to reciprocate the instrument 360 degrees clockwise, 30 degrees counterclockwise at 500 RPM. Then I use a bigger instrument to finish the instrumentation. This is high flex EDM 1.5. Again, I'm using a reciprocating motion, 360 degrees clockwise, 30 degrees counterclockwise. Now I finish the preparation. So I was successful in shaping the canal without breaking the instrument. Okay. So now, I forgot to show you how to obturate the canal with MTA. So first of all, you need to carry the mixed MTA into the canal, put it in the canal, and push it a little bit further into an apical direction with my small plugger, like this. Then I'm going to use an instrument one size smaller than the final apical size. So that is 2005 high flex EDM. So as you can see, I'm rotating the file counterclockwise, and I use a push and pull motion. So it's a combination of push-pull motion and reverse rotation. So in a clinical situation, you have to be connected to an apex locator, so you know where you are inside the root canal. Make sure you touch the apex at least twice, 3 times or 4 times, because you need to extrude MTA a little bit. So basically, I'm doing the same thing. I'm repeating the same procedure, up and down, rotating the file counterclockwise. Now I finish the compaction for the middle 1/3 here. I'm still rotating the file counterclockwise and doing an up and down motion. And place more MTA into the canal for the compaction in the middle. I'm sorry, in the chrono 1/3. So finally, I remove excess moisture with a paper point. So let's see. You see the MTA is a little bit extruded. This is ideal. If you see the end of the root here, I mean the orifice of the root, it looks very good. Sorry. So this is another case. So as you can see, this is a one visit treatment. As you can see, a big region around the second premolar, mandibular second premolar here. You see a big region, and you see the curvature. Curvature is definitely greater than 30 degrees here, mesiodistal direction. And if you look at the Bacco-Ringo aspect, you see another curvature, 33 degrees. So this curvature is considered severe. So I'm going to use martensitic phased instrument, high flex EDM. So let me show you how I did it. Then I finished the preparation with 3504 instrument. So that's why I will use number 3004 instrument to compact MTA into the canal. So I'm carrying MTA into the canal. I'm obturating the canal for the patient, this patient. I took this video yesterday. So first of all, you need to push MTA into an apical direction with a small plugger. Then I'm going to use number 3004 instrument, one side smaller than apical size. Then I use, push and pull motion. I'm connected to an apex locator. So as you can see, I'm touching the apex. You have to see this at least twice to make sure you extrude MTA beyond the apical foramen. So as you can see, I'm using a push and pull motion on MTA. So I hit the apex more than twice. If you keep doing the same thing, you will have MTA accumulation around the apical foramen. Then you see the reading going down. So I'm rotating the file counterclockwise and use a push and pull motion. So this is the combination of push and pull motion and reverse rotation. So I'm adding more MTA to the canal. I'm connected to an apex locator. I am repeating the same procedure. Push and pull and reverse rotation. This is ultrasonics. Because of the curvature, I want to vibrate MTA with ultrasonics to condense MTA more. Okay, then I finished the compaction for the apical and the middle one third. Now I'm compacting the MTA for the coronal one third. So I'm using a bigger plugger to condense MTA. I'm removing excess MTA around the orifice. Okay, now there are some cautions for the use of MTA. So remember these things. MTA is hygroscopic. So, do not keep your MTA in an open air because MTA will set. So you have to have tight container. And MTA can set if exposed to the air. Air includes moisture. So that's why you have to store MTA in an airtight container. Use slow setting MTA for canal use slow setting MTA for MTA obturation because if you use fast setting MTA, if you are underfilled, it will be too late to remove compacted MTA. So I always use slow setting MTA. MTA does not set if it's not contacted with dentin. So remember, you must contact dentin, you must contact vital tissues, periapical tissues, or pulp tissues if you are doing vital pulp therapy. MTA does not set or become porous in an acid environment. If you see inflammation, do not obturate the canal with MTA. Wait. Then if the inflammation goes away, you can do that. Handling of MTA is different from that of gallopulture. And this is, I think, the most important. Occlusal trauma delays periapical healing. So if you have a big lesion, do not immediately place a crown or restoration for functioning the occlusion. It's not good. So you have to wait until the lesions, is reduced. So I like to show you some cases. Here, as you can see, you see a double curvature here, and this is a severe curvature. I instrumented the canals, this one, and this one, and this one. Then this is a post-op radiograph showing nice MTA obturation, regardless of the double curvature or severe curvature. Another case, you see the severe curvature here. It doesn't matter. If you do the procedure that I told you, you will have the same result. And this is a case, you see an open apex. So in this case, I needed to take a radiograph with a file to the working length, estimated the working length. So I pushed MTA. I intentionally excluded MTA so that I could promote osteogenesis and cementogenesis. And this is 3 months post-op, 9 months, showing hard tissue formation MTA here. Another case here, you see the external defect, external root resorption here, obviously, and the big lesion on the root. What I did was I retreated this tooth. I pushed MTA beyond apical foramen because this tooth had an open apex. So I extruded MTA intentionally, and this is 6 months post-op showing hard tissue formation on the root end. This is not a surgical case. This is a non-surgical case. And this is 24 months post-op showing nice hard tissue reformation on MTA. This is another case with a big lesion, huge lesion around the root. As you can see, an image from the CBCT here, the tooth was swimming in the bone. If you push the tooth down, it goes down like this. So it was swimming in the bone. What I did was I pushed MTA here, like this, beyond apical foramen when obturating the canals. And this is 9 months. As you can see, you see hard tissue formation. And you see the bone reformation in the defect. Okay, remember the previous CBCT images? Let me go back. You see a huge defect around the root. But 6 months after the MTA obturation, you see the bone deformation around the root. The tooth was no longer swimming in the bone. It was stable. This is another case. You see the external root resorption. What I did for this case was very simple. You see a big lesion here on the root. I extruded MTA intentionally beyond the apical foramen. And this is the post-op, the immediate post-op, 1 month, 6 months, and 18 months, showing hard tissue formation on the defect. You see the tooth was actually longer than the day one when I retreated this tooth. Another case, this one was a through and through defect. What I did was, you see the root filling with gallopulture looked good. It was not overextended. It was not short of the apex, so it looked good. But what I did was, I sticked a file into the periapical tissues to induce bleeding. I always induce bleeding whenever I see a big periapical lesions. Then I extruded MTA a little bit. Then this one was 3 months post-op, 6 months, and 1 year. You see the lesion is completely gone. You see a nice periapical healing. In addition to that, you see the hard tissue formation on MTA. You see something here on the root end. If you compare the pre-op radiograph here, something here, something was created on the root end. This one was a perforation case. You see a big perforation here and here, huge perforation. This one. I retreated this tooth. I repaired the perforation with MTA. And of course, I obturated the canals with MTA. This one was 3 months post-op, 6 months, showing nice periapical healing compared to the pre-op radiograph. Without MTA, I would not have been able to have the result like this. So this one was another case using gallopulture that failed. You see a big lesion. What I did for this case was I just replaced the gallopulture with simple MTA. This one was an immediate post-op, 3 months, 9 months, 12 months, 24 months, showing nice periapical healing. You see the root end dissection was this is another case. The root end resection was incomplete. You see the buccal root remaining here. So instead of doing the surgery to complete root end resection, what I did was I pushed MTA because there is dentin wall here. So that's why I wanted to touch the dentin wall. I wanted to create hard tissue on MTA. So what I did was I extruded MTA to touch dentin wall here. And this is the post-op, the immediate post-op, 3 months, 6 months, 12 months, showing nice hard tissue deformation on MTA. If you compare this with the pre-op CBCT image here. So another case, you see the transportation and the perforation here, because if you look at the pre-operative CBCT image on the sagittal view, you see the original canal here. This is the perforation. So the original canal was behind the perforation on this side. So what I did was I removed the curvature. Then I was able to get into the original canal here. This one was red. I obturated the canals with MTA, the same technique I showed you, and I repaired the perforation with MTA together with MTA obturation. And this one shows nice periapical healing 6 months after the MTA obturation. You see, if you compare this with the preoperative CBCT images, you see nice periapical healing. Nice, nice, nice. This is a horizontal root fracture case. You see the root fracture, big one, big one, big one. You may want to extract the tooth like this, but the patient insisted on saving the tooth. So I respected the decision made by my patient. So what I did was I extruded MTA into the defect, into the fracture. And this is 3 months, 6 months post-op showing nice periapical healing, including the fracture line here and here. The tooth became very stable. There was no percussion pain, and the tooth was asymptomatic completely 6 months after the MTA obturation. And I think I have 2 more cases. You see big periapical lesion. There was no sinus floor. This is a maxillary sinus. So this is almost like a through and through case from the oral cavity to the sinus cavity. So what I did was very simple. Again, I obturated the canal with MTA, and I pushed MTA beyond the apical foramen. This is a post-op, immediate post-op. And 3 months, 6 months, 6 months radiograph and the CBCT images showing nice hard tissue formation and also bone deformation. You see periapical healing compared to the pre-op radiograph and the CBCT images. Another case, this case shows a failure with the surgery. As you can see, the root end dissection was not complete. So what I did was, instead of doing another surgery, I extruded MTA. This tooth was, almost like an immature tooth. You see an open apex. So I extruded MTA, and this one was 8 years after the retreatment. You see the bone deformation on MTA, you see the hard tissue deformation on MTA. So actually, you see the hard tissue on MTA. The tooth was longer compared to the pre-op radiograph. Okay. Thank you for your attention. Thank you for coming. Thank you for being there. Thank you for staying home in this epidemic. So maybe let's go back to the first page because I was not successful in showing the video. Now I'd like to show you the video here one more time, then I'm done. So here, if you missed the video, it's strange. I'm sorry. Do you see the video? I guess the video does not want to be shown. Okay, okay. Let me give it a try, another try. It's very funny. Why the video is not on? Do you see the video? Yes or no? Oh, maybe yes, yes, yes. One more time. This is a focusing speed with a Zoomax microscope. Do you see that? Okay, okay, okay. If you let me show you the zooming speed with a Zeiss Pro Ergo, because the zooming speed and also the focusing speed of Zeiss microscope is faster than that of Zoomax OMS 200. So let me show you zooming speed like this, very quick. And focusing speed with a Zeiss microscope. So let me show you again. This is a zooming speed of Zoomax microscope, a little bit slower than Zeiss. And focusing speed. And I'm showing inclination angle, 60 degrees. Very flexible, like this. And the clicking sound is very quiet. You don't feel any clicks on your hand. But if you look at the Zeiss microscope, you see the clicking sound is a little bit noisy. The inclination angle is 30 degrees. I want it to be more than 60. But Zeiss microscope, of course, is very good. I've been using it for more than 25 years. So this is what I wanted to show you. thank you for coming and goodbye for everybody. Bye-bye now. I hope you enjoyed my presentation. See you around. Good night.